Okay, I assume this is working good. So I'm very glad that everybody invited me back. I thought after last year's little session you might not want me back again, but this year I'm even tackling a more difficult and challenging subject, dizziness. Now I'm not here today to bamboozle you with evidence-based medicine, complex CT scans, MRI scans, or weird and wonderful vestibular function tests. That's my job. I'm here today to talk about a pragmatic approach to a rather interesting group of patients, or approach to dizzy patients in the primary care setting. I've got GPs that are friends, good friends of mine, and I know you guys have got limited time, so this hopefully will change possibly the way you think about dizzy patients, so some seeds of thought, and I'm also open for questions at the end, things that you find challenging. And hopefully I'll finish in time that you can ask these questions. And hopefully you're not too dizzy by the end of all of this. So my name's Glenn Watson. I'm a neurologist. I'm based at the Royal Hallamshire Hospital in Sheffield. And again, thank you for inviting me to come and chat today. So some of you from last year may recall why I have such an odd accent. And I'll put this to rest now and we can carry on with the slides. So initially I grew up in this country. Some of you may well have watched the rugby game a couple of weeks ago, so I had to put that slide in. So I grew up in Johannesburg, went to medical school in Johannesburg, and came to Manchester to do postgraduate training because I thought the weather was just too nice in South Africa. I didn't realise it'd be so wet in Manchester. I subsequently finished my ENT training in Manchester, did a year of neurology in Birmingham. We fondly used to call this building the toilet bowls because when it rained it was hollow in the middle and the rain used to pour down like a big toilet bowl. I then did a year in Sydney in neurology and finally ended up coming to my senses and moving to the far warmer and sunnier climates of Yorkshire and live in a little village called Cawthorne in the edge near Penistone. So I love this question, or when a patient comes in, and I'm sure you all do as well. Doctor, I'm feeling dizzy. Now, I'm not sure if that picture's me or you or the patient, but I've just come out of a dizzy clinic myself. I think I was starting to look like that by the end. Okay, these are your heart sink patients. Often they come with a host of rather nondescript, vague symptoms. Often we think, are these guys malingering? They're repeat attenders. There's a complex interaction, psychosocial interaction with possible secondary gain. Often you think, my goodness, these guys are impossible to unpick. You'll be sitting with the constraints of, I just don't have enough time for these people. There's also that nagging thought at the back of your head, what happens if I'm sitting on a stroke here? So there's always that worry with some people, oh dear. And then you think, you know what, can I just give them something and just get them out of my room? Trust me, I think that way sometimes as well. And I have 45 minutes with each one of these patients. So the aims of this, just basic aims. It's a basic understanding. I'm not going into the physiology of the vestibule, but just understand the nuts and bolts of it. Appreciate some of the signs and symptoms because not everybody has labyrinthitis and not everybody has Meniere's disease. Awareness of some of the acute pathology, which I'll go through, when to worry and who to refer to, and discuss simple treatment options, something that you guys can do in the primary care setting. In order to achieve that, well, I hope I achieve it, we'll just go through some basic anatomy and physiology, some of the questions I find very useful in my clinic. We'll go through 6 of the most common pathologies. And if you know a little bit about these 6, you'll probably cover most balance problems from the peripheral system. I'll briefly touch on central pathology. At the end of the day, I'm a simple ear surgeon, not a neurologist. We'll highlight some red flag problems, discuss some simple medical and therapeutic interventions, some of the pitfalls, and there's 1 or 2 you've got to be very careful of, and that old nugget, the DVLA. And again, it's very simple to deal with that. It's a great slide, isn't it? If you're a migrainer in this room, this is hideous. It's hideous for most people. I love showing people this and go, does that bother you? And people go, oh, that's horrible. But the definition of dizziness there's numerous definitions, and some of them are really great, but the one that comes up all the time in the Oxford Dictionary is vertigo or spinning. Can be imbalance, can be lightheaded, can be off balance or disequilibrium. You can see already it's getting complex. It can be stumbling, faint, detached, or brain fog. My favourite's mental confusion. Now, in my world, this is a busy slide, and I'm sure these will be available to people. It's on film as well. But I am concerned as an ENT surgeon about the top one, vertigo, spinning. Is it an illusion of the room moving around the patient in circles, or the patient moving around a fixed point? Often it comes associated with a lot of feelings, autonomic arousal, so they're going to be nauseous, vomiting, sweating, pale with GI complaints such as diarrhea. The imbalanced patient, or the off-balance patient, is usually somebody who is prone to falling, veering from side to side and stumbling, not necessarily vertiginous. This can be exacerbated by poor vision, lack of visual input, proprioceptive problems, musculoskeletal problems, and possibly mood disorders. The bottom two are an interesting group. The fainters are the pre-syncopal ones, particularly on standing. These tend to be people with low blood pressure, orthostatic problems, hypoxic patients, patients with cardiovascular conditions, polypharmacy, and the lightheaded, detached, brain fog, swimming in treacle, all the very odd symptoms often come hand in hand with mood, anxiety, and maladaptive behavior. The interesting thing is all of these can interact with each other in a dizzy patient. Let's get on to the simple stuff. So sitting deep inside the temporal bone in your head is this guy. The cochlea we will leave today. It deals with sound and hearing. It is coupled up to the vestibule. So just as a caveat right from the beginning, labyrinthitis has to be complete failure of that. So hearing loss and balance problems. If the hearing is preserved, they do not have labyrinthitis by strict definition. If you go onto the vestibule, it's a rather odd looking chap. You've got three semicircular canals orientated to 90 degrees and paired up with one on the other side of the head. There's a superior canal, the lateral canal, and the posterior canal. The semicircular canals sense rotational or angular acceleration and deceleration. In other words, when I turn my head or I move my body from side to side, they sense the movement and they adjust my eyes at the same speed in the opposite direction. You can do it yourself. If you move your head from side to side, your eyes move in your head, the doll's eye reflex. These are stabilizing your gaze, the semicircular canals. It's called the vestibular ocular reflex. At the front is another little group of balance sensors where the strange crystals that you may have heard lurk. They're called the utricle and the saccule, the otolithic organs. Essentially, there's two sensors with a jelly-like membrane embedded onto the hair cells, weighted with calcium carbonate crystals. Those are the voodoo crystals in your head. And they respond to gravitational acceleration and deceleration in the X, Y, and Z plane. So if I push you forward, you know you're going forward. If I push you back, you know you're going backwards, side to side, up and down. And they work very closely with the cerebellum and the vestibular spinal reflex, working with the core and anti-gravitational muscles. Pretty simple, guys? Honest, is that okay? Yeah. So these guys control your gaze. Keep it simple. The two little odd chaps with the crystals in them, those voodoo crystals that float around in your head, control your gait, your walking stability or your gait stability, together with other systems. People get fixated about the ear. Dizziness has to be the ear. Off balance has to be the ear. As a neurologist, I go, not completely. The ear only contributes 15% to your overall balance. Yes, it's an important component because it's your internal reference point. I could stick this room into a pitch black void. I could suspend all of you from ropes. I could push you, I could turn you with no visual input, no proprioceptive input, and you would know this was happening because of your ear. The ear takes the information from the eyes, it takes the information from the joints and says, yep, it's correct, that's happening. Musculoskeletal and proprioceptive contribute 15% to your balance, and 70% as a species. Humans are very, very visually dependent. We rely on our vision. So 70% of our balance, strangely, comes from our vision. We can see where we're walking, we can determine that the floor is flat, it's tilted, it's sloping away from us, it's uneven, it's crumbly, etc. We can see things coming towards us, so we know to avoid and negotiate around things. So all of these things, all of these components need to be working in harmony together with the brain to keep us steady. This is where I try to simplify things. I'm sure all of you have been on an aircraft. Well, I hope you have, and I assume most of you have, but in this day and age. The way I try and explain it to patients, because when they come in, they're stressed, they're anxious, they think they're falling to bits, they have a hideous brain tumor, multiple sclerosis, and they're going to die. Honestly, it's nowhere near as bad as that. But what I try and explain to patients is balance is a bit like an aircraft. Okay? For an aircraft to fly, or a pilot to take off from airport B and land, airport A and land at airport B, he needs a number of components to be working on that aircraft. He needs 2 engines that have correctly fueled and have got fuel lines feeding them the fuel. Those engines represent the labyrinth or the vestibule on either side of your head. The plane needs to be intact. It needs a fuselage, it needs wings, and it needs vertical and horizontal stabilizers at the back. That's your musculoskeletal and proprioceptive system. The pilot needs a window to look out of. It needs to be clean and intact. That's your vision. The pilot himself is your brain. So that pilot, like your brain, with the ears, the joints, and the vision, is taking all that information from that aircraft and flying it from point A to point B in a steady fashion. The pilot needs fed and watered, just like your brain needs glucose and oxygen. Okay? Are you guys working with me on this one? And the pilot needs to be calm. Captain Sullenberger, two bird strikes, 2 engines out, the guy lands a fully laden, fully fueled aircraft on the Hudson River. Amazing piece of flying. You don't want to get onto a plane with a pilot who's nervous and jittery. You don't want to get on one who goes, oh my goodness, there's a rain cloud coming, and he's sort of sitting like this behind the control because he's frightened. No, patients with anxiety, mood disorders, that's how they fly their plane. They could have the best engines, the best wings, the best stabilizers, the cleanest window, but they're kind of flying it like this. So that plane's all over the sky. Chronic subjective dizziness, call it what you want. This group are difficult to deal with because you need to control their mood disorder before you can control anything else. Is this working with you guys? You hope you don't see that when you're sitting on the aircraft, because I'd be pretty worried if I saw that. So I'm going to keep with the aircraft thing for the time being, because patients, and I hope you guys appreciate it. That plane's just taken off, everything's hunky-dory, and bang, that engine's gone. You've got an engine failure. Okay? And that could be vestibular event. I try not to label people with stuff until I know what they've got. Labyrinthitis, Meniere's disease. Just think about it. I'm flying along hunky-dory, an engine on my left goes. That engine's working. What's it going to do to the plane if you left it alone? It's going to push it around the sky in circles. Theoretically, it does other things, but let's keep it simple. You're just going to go round and round. Well, what's that? It's the illusion of spin. It's vertigo. That's why they get vertigo, or genuine vertigo, because the good ear has nothing pushing against it anymore, so it's just going to push you round and round in circles. Your eyes would like to follow suit in your head. They'd love to go round and round in circles as well, but there is some physiological and anatomical constraints. They can't. They're tethered by muscles. So the eyes will drift off target because the good ear is pushing the eye. The brain or the pilot suddenly goes, hang on, where are you off to? Where are you flying to? You're flying over there all of a sudden. The runway's over there. And the brain corrects the eyes. Drift, correct. Drift, correct. That's nystagmus for you. Simple. Well, I hope that's simple, guys. So the good ear will always push towards the bad ear. The eyes will drift off target. and the brain will correct. And nystagmus is named after the corrective phase. Okay, there is a law that we follow in ENT. It's called Alexander's Law. And it's a law that you guys can apply in the GP practice, provided that nystagmus, if you happen to see a patient in an acute setting, it may be a domiciliary visit, will always, medicine's never always, but probably more than 95% be horizontal, so on a vertical plane. It'll be towards one ear only, not in both directions, not up and down. And if you had to get the patient, if they will tolerate it, to look towards the better ear, the nystagmus would speed up. That's Alexander's Law. If I get a patient coming in following that law, I'm pretty certain it's probably a peripheral problem. If it's not obeying that law, I start to get slightly worried myself. Okay, you're with me still with this? Hopefully. So as a species, can you imagine if we were back in the Dark Ages, back in caveman Neanderthal time, if we got vertigo and lay prostrate on the ground, vomiting, and not being able to get up, we'd certainly not last very long as a species. We'd all be eaten by a saber-toothed tiger or have died from severe dehydration and malnutrition. So the human body has a braking system. Okay, so what it does is, the pilot goes, oh, the engine or the brain, one engine failure. I'm spinning for a few hours. Then goes, I can't keep on doing this. I need to do something. So what the pilot or the midbrain does, or the vestibular nuclei, on the good side, it down revs. On the other side, where the problem's happening, it up revs. Up regulation, down regulation. In other words, brakes come on, and the spin slows down. Over time, with rehabilitation, the brain adapts to abnormal signaling coming in from a poor vestibular apparatus. Whilst that's going on, people lean on the other balance systems. People lean on their vision to keep themselves steady. So often you'll hear people with migraines, vestibular migraines, looking where they're going all the time. Feeling. You get patients that come in and they're sort of feeling their way around a room. They broaden their gait. This is adaptive behavior. And that's fine, as long as they don't remain in that adaptive or maladaptive state. Brings me neatly to this substance, Stemetil. Be very careful of this guy. I'm not against him. He's a very good substance, short term. If you look at CKS NICE guidelines, it even states in there, short term. You use it to stop the spin for about 4, 5, 7 days. The patient needs to stop taking it after that. They use it only in emergencies after that, because the reason why, it's a central dopamine, anti-dopamine acting drug. It switches off both vestibular nuclei on either side. So if you've got a patient who's been on it long term, they're getting no input from the vestibular apparatus on either side. They become tin men, and I had one in my clinic today. She's been on Stemetil 3 months. I kid you not, she walked in rigid. She wouldn't move her head because when I move my head, my vision moves around because there's nothing stabilizing her vision anymore. She's got neck problems because she's got a rod up her neck and the muscles are all in spasm. She's broadened her gait. She's got a stick in front of her, and now she's trying to tilt her eyes down to look where the chair is. And she's feeling her way into the room. And that's why I've got that picture. That's what happens on Stemetil too long. Literally is an aircraft lying on its wings on a beach in bits. It takes a long time to get these patients off of the stuff and rehabilitate them. And there is definitely 100% a psychological addiction to it. People are really scared. They then go looking for sonarazine, cyclazine, promethazine. That's not the answer either. They need VOR, which I'll get to, rehabilitation and physio. Other engine problems, and I'm keeping this theme and I'll get onto proper pathology. Benign paroxysmal positional vertigo. Those pesky crystals in your head floating around. Well, they are really. They've just got into the wrong place, and I'll get to where they end up. I call it dirt in the fuel lines. There's nothing wrong with your engine. It's just got a bit of muck in there that we need to shift out the way. Vestibular migraine, that's that guy. Your over-revving engine. So migrainous patients, the whole wiring in their brains, hypersensitive. They don't like bright lights, they don't like patterns, they don't like intense smells, sounds generally. But there might, if you've got a history of classic migraines, and then suddenly you start to get spin, it's misfiring on the vestibular nuclei in the end apparatus. It's the glowing hot engine. One engine's firing at 1,000 RPM, the other one's at 5,000. That's off balance, you're spinning. Very, very common, and I'm telling you what, most of your balanced patients will have that problem rather than the other weird ones. Meniere's disease, grossly overdiagnosed by everybody, not as common as it appeared to be initially because vestibular migraine's the great mimicker. It's not dissimilar, the two symptoms. That is an imbalance in the fuel in the engine. The inner ear is bathed in endolymph, which supports all the sensors. So it's a bit like your aeroplane. It's supposed to fly in kerosene, and you've shoved a whole load of diesel in it. It doesn't like it. It goes wrong for a while. Anybody heard of this condition? In a row of hands, superior canal dehiscence syndrome. Anybody? He's a new kid on the block, 1998, so not really that new anymore. This is a really odd lad. There's absence of the bone over the superior canal, so it transmits pressure and sound energy into the vestibule. These are your patients that you genuinely think, look, mate, you've lost the plot. Because they come in and say, when there's a loud noise, there's pressure changes, the world moves around me for a few seconds. But doctor, I can hear my eyeballs scratching in my head. I can hear my food digesting all the time, my joints creaking all the time. It's hideous, and you go, look, there's no hope for you. There's a lot of hope. I'll touch briefly on this. It's very interesting, and there are, I must admit, a challenging group of patients. The key to ask them to hear your eyeballs scratching, because they will go, oh yeah. Just to go on other bits of the plane that will contribute to imbalance. If you've got a dirty window, in other words, visual problems, you lose a lot of visual input. These are the patients that may well stumble, trip, fall in dark, unfamiliar environments, uneven surfaces. The old rusty fuselage with damaged wings and stabilizers, that's your joints, your muscles. Somebody has a midline incision, which nowadays isn't as common because of laparoscopic surgery. Your core muscles are weak. They're generalized wobbly patients on the leg, have a tendency to veer from one side to the other and fall as well. Your damaged pilot, anything that damages the brain will damage the pilot. That's a foregone conclusion. Your unfed pilot, just watch out for this group of patients. There's not enough glucose and oxygen getting up there. So that will encompass your cardiac patients, your pulmonary patients, your anemics, your diabetics, your fad diets, vasculopathies, and central acting medication. And just watch out for your twitchy pilot, your anxiety and depression. If we don't get that, or if you guys don't help us get that under control, we struggle with our rehabilitation and engagement in rehabilitation. That's what I said, that's what your old geriatric patient looks like. I mean, plane's still there, bit knackered. Window's gone, who knows where the pilot's gone to, AWOL across the moors. A bit of rusty old fuselage, wheels are gone. And often we'll get these patients in my balance clinic, and they're not vertiginous, they're not spinning, they're just wobbly. But they've got cataracts, they're on varifocals, they've got hip replacements, they've had midline incisions, they're on a host of medications, and you go, where do you want me to start? Maybe you should go and see a geriatrician with an interest in falls. My job as an ENT surgeon is just to make sure that the engines aren't aggravating the problem. And then BPPV is quite common in elderly. So let's get back to proper pathology and let's leave the aeroplanes parked on the runway. Often when you get a dizzy patient, there's a few key questions that I like to ask. I understand, I mean, you guys have got 10 minutes per patient. I've got 20, 30, 40, 50 minutes depending. So obviously I've got a lot more time. But some of the key ones you want to know, is the room spinning? Does it go round and round and round, making you feel sick, physically vomit, possibly turn pale, sweaty and clammy and get diarrhea? When did it start? I had a patient today, it started 30 years ago. I was like, got to go back a long way here to try and unpick all this. You know, if it started, that's always important for myself anyway. Was there any change in the hearing with the attack? Was there any tinnitus, which is a hissing, whining or droning inside the head? Was there any pressure or oral fullness with the attacks? How long did they last? Are we just talking seconds? Are we talking minutes? Are we talking hours? Are we talking days? Have they had infection, be it an upper respiratory preceding or an ear infection? Is it related to head position? And this is your BPPV. So when I look up, I look down, roll over, the room momentarily spins around me. Is it made worse by head motion? So remember, the engines or the vestibule controls your gaze stability. So a lot of patients with balance problems won't move their head. They don't like it. So I often say, when you move your head from side to side, does it feel as if the world's rattling around inside your head, or is your vision moving from side to side, or what you're looking at? Is there a headache with sound and smell and light sensitivity? Migraine. Really important. Autophony, strange old word, hearing internal sounds. The guys with the eyeballs scratching, the food digesting, the joints creaking. Medical conditions, I like to look at the whole package, so the entire plane. What else is going on that will contribute to imbalance? Polypharmacy, just watch if they're on lots of different medications, particularly those controlling pulmonary and cardiac problems. And in the elderly. And I've got a few patients who were, say, 14 stones, suddenly dropped down to 10, and they're still on medication for 14 stones. And you look at their blood pressure, and there's a huge diastolic and systolic drop between lying and standing. They just need to change their medication or reduce it. I always like to ask, and I'm not as scared now about asking about mental health problems. It used to be a bit taboo and people used to veer away, but I will ask, are you an anxious person? Do you like to be in control of things? Do you have mental health problems? Who are you under looking after that? What medication has been used to date, and in particular prochlorperazine? It's an absolute disaster to use long term. And are you known to ENT? Somebody may have already done all the MRIs, CT scans and vestibular function tests, and I just need to pick up where it was left off. Examination, for those who are comfortable. If you're not comfortable doing it, don't do it. Okay? That's just a simple message. But all of us are capable, hopefully, of looking in an ear and seeing, is it healthy, or has it got a middle ear full of muck or horrible smelly stuff in keeping with the cholesteatoma? Nystagmus, just remember the simple rule: of one engine fails and the other one's working, it's going to push the eye towards the bad engine and the brain will correct. That's nystagmus. Simple. Okay? You may or may not see it, because by the time you get that patient, the attack might have been and gone. So you may not see anything. Just check if I look at cranial nerves, because you may be sitting on a stroke, so just be careful. Head shake, if you're comfortable. The way I do a head shake is you tell the patient, you're not going to like this, and you literally get the two cheekbones and you do that to their head for 20 seconds. Why am I doing that? Is if one ear is good and one ear is bad, every time you turn it, the good ear will charge up because it's working. The bad ear will lag behind. And you'll unearth nystagmus. You'll start to see it. It's a simple little test. You just say, close your eyes, put the head slightly down and give it a good old shake from side to side for about 20 seconds. Just watch the slightly elderly patients with neck problems. You know what I mean? You know where that could go. So you don't want to go and end up with serious problems. It's just a gentle, just off-center shake. Anybody heard of Romberg's and Unterberger's? Romberg's is really simple. I love doing it. Basically, get them to stand still, hands by the side, close their eyes. When you close eyes, you remove visual input. So they start to do the old sway around the hips and the heels. I'm quite happy, everybody will sway. But what I don't want to do is this sort of huge swaying and then having to open eyes and step to the side to stabilize. That's telling me that, yes, the ears might be contributing, but I've also got to think about joints, proprioception, and muscles. Unterberger is another favorite, where you get them to put the palms up to look for drift. I get them to march. I hold on to their hands. I then tell them to close their eyes, and I can feel if they're starting to lean from side to side, and then I take my hands away. And then you can get all sorts of turning, moving forward, which will give me a rough idea of what the muscles are doing, possibly if the ear's contributing to it. If you're not familiar with the test, don't worry about it. Gait, it's always useful to get somebody to walk up and down, just to see if they're broad-based, if they're stumbling, if they're veering. And Dix-Hallpike, I don't know if anybody's familiar with that. Some people who have done ENT maybe is to look for benign positional vertigo. It's essentially, you get the patient to lie with the back to you. I always sit and do it. So I get the patient head turned 30 degrees, bring it down over the edge of the bed and lean. My elbow, it's got the head on it, and my leg's taking the weight. Because you don't need to put your own back out. So I always do it sitting. And you're looking, and I'll go into it for very characteristic movements of the eyes. Most patients go, ooh, I don't like this, and close their eyes. And you're like, open your eyes, I need to see what they're doing. And often I find a little trick is just to get the edge of the eyelid and lift it up. Because inevitably people go, I don't like it, and shut their eyes. So some of the peripheral vestibular problems I'll go through in order of frequency that I see, and I've seen about 300-400 balance patients over the last 4 years. We'd be vestibular migraines without a doubt. It's the most common problem. BPPV, and everybody forgets the lateral canal. It's also angulated 30 degrees down, so debris can get into it. The problem with the lateral canal is we live in a horizontal world. So if it gets in there, it's a nuisance. Vestibular weakness or neuronitis. I don't like labeling it, so I just kind of keep it a broad term. Labyrinthitis, just remember that's hearing loss and balance problems. Meniere's disease, superior canal dehiscence, I'll touch on it. And then these other characters, just you don't need to worry about them. Vestibular migraine, the great mimicker, the over-revving engine. Okay, the Bharani Society and International Headache Society now recognize this condition. Okay, and the next slide just goes through the classification of it. But essentially, it's a misfiring or overfiring of neural activity on the vestibular nuclei and the vestibular apparatus. It's the guy who's straddling between the peripheral problem and the brain. He's got his feet in both camps, the vestibular migraine. Females slightly more prone to males because of monthly hormone fluctuation, oral contraceptive pill, and then it changes its spots slightly around about menopause. Often patients will know their triggers. If you've dealt with migraine patients, they'll go, ooh, stay away from chocolate, or cheese, yep, that causes it. Caffeine's a big killer. MSG, nasty stuff. They put it in all sorts of foods as taste enhancer. KFC puts it in, Doritos, Pringles, Chinese food. Some people are incredibly sensitive to it. E621's its other name. Red wine, I know we all like it, or most of us like it, can be a problem. Sweeteners, believe it or not. I've got a few patients sensitive to avocados, pineapples, bananas, peanuts, cured meat, and soya-based products. This is an odd chap. Some people have the problem, barometric pressure changes. So I say when it's nice and when it's a bit grey and murky, that's low pressure. When it suddenly becomes high, beautiful blue skies you can see for miles, that's high. And they go, yeah, oh, things start going wrong when that happens. These slides are available to you, but the questions I want to know, have you had migraines in the past? And often they'll say, yep, I've had the flashy lights, I've got the banging headache, it's throbbing if I increase my activity, I just end up lying in a darkened room, sound, smells, light, really annoy me. Then the headache went away, and I'm starting to get these weird balance problems. You do not need to have a headache with a vestibular migraine. We like to know it's there in about 50% of the times. But this is the International Headache Society classification. I also like to know if they've had a balance problem, how long does it go on for? These are your patients that will say, well, the room spun for hours, it spun for days, it was awful. I did get a bit of oral fullness. My tinnitus did change a bit. My hearing, I think, went a bit. And you go, oh, I know this. This is Meniere's disease. No. If it goes on for more than 12 hours, it is not Meniere's disease. Meniere's disease only goes on for 12 hours, maximum. These guys go on for days. There's an odd caveat, they can go on for hours and minutes, but yeah, that's when it gets more challenging. And there is a very small group with Meniere's disease and vestibular migraines. They're really challenging. And if you get the slides, I've got the link to the Headache Society, so that's there. So you just need to put the link in. Okay, so we've been through that. Often they feel hungover. You say, well, after the attack goes, how do you feel? And they go, oh, I feel awful, doctor. It's terrible. I just feel like I've had too much to drink. I don't like moving my head around. It's really awful, and it takes a few days to settle down. Often these patients go on to develop another maladaptive behavior called visual vertigo or persistent postural perceptual dizziness. I'll get to that a little bit later. Often an interesting question I love, I say, how good are you as a passenger? This lot don't do car journeys very well. They're okay if they're holding a steering wheel because you're getting proprioceptive input through your hands. But put them in the back of a car or a bus or something, they just fall to bits. Say, oh, do you do fairground rides? Oh no, doctor, don't do that. And often, for those who do watch Strictly, you sometimes see contestants that do the dances with a spin. See how much I know. And they don't do it, they hate it. They wear these little anti-nausea bangles because I bet if you were to ask them, half of them would have migraines. Okay, so how would you treat it if it came to see you? Okay, it's obviously challenging because you don't have the facilities we do, but simple things you can do is lifestyle modification, often with a lot of balance things. Try and control stress and anxiety, some outlet, Pilates, yoga, something to relieve the stress. If they can work it out, and I give them a dietary sheet, can you find your triggers? Try and avoid them. Go to Holland & Barrett's, go and get some magnesium supplements and vitamin B2 supplements. It's a neural membrane stabilizer, very useful. It's not going to do any harm, and they can try it. TMD, temporomandibular joint disorder. The jaw joint is supplied by the trigeminal nerve, which is the main culprit in migraines. So I've got 1 or 2 patients that are habitual grinders and clenchers, that once they got the bite guard and got the TMD under control, the migraine settled. You can use the usual characters, Stemetil, cyclizine, cinnarizine, for acute episodes. 3-4 days maximum, just be wary going beyond that. Abortive medications such as triptans don't work with this group. I will then, if you follow the NICE guidelines for migraines, and I've had a lot of patients bounce back from neurology, I'll put them on prophylactic medication. That's a bit old school amitriptyline. It comes with a host of sedating, so they need to take it at night. But they can start with 10 milligrams before they go to bed. I do warn them about blurred vision, dry mouth, and people with urinary problems. It can cause problems there, so you need to watch. I'll tell them if their attacks continue, they can go up 10 milligrams every 2 weeks till the attacks are under control or 60 milligrams is reached. If you think that's too clunky, you can use nortriptyline in a similar fashion. You can use beta blockers, but watch out for your peripheral vascular disorders and asthma. And topiramate. I'm not a big fan of this topiramate. It does work in some people, but it really, in some people, make them really forgetful. They slow down. It can aggravate balance problems. Starting to veer towards venlafaxine, but I'm just very careful that they're not on any other SSRIs, and they may need to come off or I'd work in conjunction with the GPs. We'll get back to VOR exercises. And I'd also just watch out for maladaptive behaviour, such as anxiety and mood problems associated with balance, because sometimes they need to be controlled as well. This is your crystals in the head. BP, dirt in the fuel line. Basically what happens is the little crystals that sit in the sacculonutricle shear off, and because the posterior canal is the most gravitational dependent, they sit on the floor. So if you look up, look down and roll over, they slosh around in there. But when they start sloshing around, they trigger the sensor. And the patient then, although the patient's lying still, the ear's saying, hang on, no, you're moving. And they get a very brief, intense, 10 to 15 second episode of spin. Often they don't like going to the hairdresser because they're having to put their head back to get their hair washed. They don't like the dentist because they're tilting their hair back. And bizarrely in Sheffield with the trams and buses, because it's so steep, some get attacks going up to the hospital when the road pitches over 10 degrees. I sometimes ask that. It's often associated, you'll usually have a preceding, it could be minor or major head trauma, because the bang to the head shears the crystals off, the otoconia and the membrane off the receptors. It can be associated with inner ear disorders such as suppurative conditions. And just be careful, if I get somebody who keeps on getting BPPV, you need to check the vitamin D levels. It makes those crystals brittle. And often if you put people on vitamin D supplementation, the BPPV, once you shift the crystals, settles. How do we check for it? It's called the Dix-Hall pike. You literally get the patient's head and hang it off the back of a table, being careful about their necks. And honestly, their eyes, you'll wait, the head will come back, nothing will happen, and suddenly the eyes just start shooting up towards the top of the head and rotating to the downward ear. So literally it's going up and rotating, and it's really intense. And patients really, really dislike it, but it lasts a few seconds. The lateral canal we deal with, but you just have the head pitched up at 30 degrees and they literally look over their shoulder, one side to the other, and you can see horizontal nystagmus. How do we get rid of it? I wouldn't, look, if you're not happy doing any of the maneuvers, don't do them, bottom line. Because you can shift debris from the posterior canal into the lateral canal. You can convert them. And if you convert from posterior, and we don't live in a vertical world, to a lateral canal, which is horizontal, the patients are miserable. Really, they don't like you. But if you are comfortable, you can do what we call the Epley's maneuver, which literally you bring the head back, You then rotate to the good ear. You get the patient to rotate 90 degrees round with the nose pointing to the ground, and then they sit up with the head tilted down. And each maneuver is about 45 seconds to a minute. If they move their head up from that horizon, you can convert it into a lateral canal. For us, it's fairly straightforward to deal with. We just do a barbecue roll, which literally, it says on the tin, you rotate them 360 degrees. But if it happened in a GP surgery, you've got somebody who's now vomiting on your shoes, vomiting on the carpet. They walk out there, an absolute disaster, and you think, I've broken them. I've seriously broken them. All I did was put the head back and I've done something horrible, and the panic sets in and it's not very pleasant for you and the patient. I must admit, when I do it and convert, and I have converted a few, you do go, oops, what have I done? And I've got a very good neurophysiologist, and we take them off to the balance room and calm them down and calm my heart rate down, and we do the barbecue roll. Okay, there is a cruel one called the Siemens maneuver, and I've seen it done a few times, which to me it's a bit drastic for posterior canal. You literally have them looking over their shoulder and you go, get ready for this, and you go, whoomph! Now I think if you're a big rugby player and you're fairly fit, yeah, that's okay. But if you've got a slightly sort of frail elderly patient and you're throwing them around the bed, you're looking for trouble. So I tend to avoid this one if I can avoid it. We use it in special circumstances. Brandt Daroff, you may have come across leaflets for it. It's not going to do any harm, and the patient literally goes home looking over the shoulder, flopping to the left side, so over the right, to the left for a couple of minutes, sits up and repeats on the other side. It's a habituation exercise. You might be lucky and it might shift the crystals, but it may not. It's not going to do any harm. That's what's coming. If I can convince our managers to buy one, that's what's coming. I've had a go in this. This is great fun. It basically looks like a fighter pilot's chair. And you literally strap the patient in. So those patients with mobility problems, neck problems, frail, elderly, young, you sit in that, you don't do anything, and the chair just does all the work for you. I've just got to convince them to fork up £70,000 and reinforce the floor in the vestibular room so it doesn't crash into the diabetic clinic below, because it is a huge counterweight. I'm still working on it. Bizarrely, Leicester's got one, but they've had 7,000 referrals into Balance Centre over the years, so can't take outside referrals. Gives me more ammo to get my own. Vestibular neuronitis or vestibulopathy, I tend to just keep it vague. Patients like to look at things on the internet, so the more vague you keep it, they don't go home and get multiple sclerosis, and Dr. Google doesn't have them dead, buried, and gone within a day. That's the partial engine failure. So yeah, I wouldn't like to look out the window and see a bit of cowling poking up in there, because I'd like to know what's going to end up with that and where it's going to go. Usually these patients are fit well and they've maybe had a cold, a runny nose, and then suddenly they wake up and that room is going round and round and round, and they're feeling grim, they're green, they're vomiting, they're not very happy. Often they've got sweating, they're pale, and you go there or you see them and you go, this doesn't look good. Now, I must admit, if you go there and somebody's prostate and vomiting and not great, it's very difficult to look, because often they have their eyes closed. Often it's difficult to tell if there's nystagmus. But if you could see the eyes, and as long as it's beating horizontally in one direction, and if you look towards the fast beat and it speeds up, you're probably obeying Alexander's law. It probably just is a peripheral vestibular problem. Head shake if they'll let you do it. I'm not sure, I mean, I can do it because by the time I see these patients, they're long over the acute event. But if you had to go for a domiciliary visit and they've been vomiting all over the place, I'm not sure they're going to let you do it. Check they've got no hearing loss. So a patient who says, the room's spinning and I've lost my hearing, I'm telling you right now, guys, I'm quite happy for you to call it labyrinthitis once the medics have excluded a midbrain stroke, not beforehand. And I don't want that on my ENT ward. Somebody with a stroke in the midbrain with brain swelling and cerebellum and an ENT ward, with tracheostomies in head and neck patients, and surgical ward, no thanks. Just check in those patients if you can for cranial nerve problems, if you're able to. Vestibular neuronitis, vestibulopathy, labyrinthitis, these patients will weight bear. They will stand up. They might not like you, but they will take their own weight. If they've had a stroke, they'll get up and they'll fall over. They will not be able to weight bear, and that differentiates too. If you can't do anything else and they fall over on standing, he goes to medics. They've had a stroke until proven otherwise. Just check the ears if you can. It might be wax in the way, there may be things there, but look and check there's nothing hideous going on in there. So say it's very mild. Say they're okay. They're spinning a little bit, but they're okay. They're not dehydrated. Yes, you can use Stemetil, cyclizine, cinnarizine, promethazine. It's fine. Just check there's no contraindications. Only use it for a short term. Don't use it long term. Because as I said, it will cause problems for us down the line. Steroids, antivirals, sedatives, don't bother. They don't work. There's no evidence that it should be in the CKS NICE OSA say so. If it's severe and you're happy that it's just the ear, they're dehydrated, they're miserable, phone ENT, get her advice. You probably find it'll be a junior and say get it to the medics, but just speak to them. Okay, Barnsley or Sheffield or wherever is the closest ENT department. As I said, if it's associated with any other neurological, can't wait there and severe headaches, speak to the medics. Speak to your neurologists, depending on what service is available. Once I've taken the medication and things are settling down, I still don't think for a few days or a week thereafter they shouldn't really be driving. They shouldn't be operating machinery that's going to put themselves at risk. Try and avoid alcohol because it will exacerbate any balance problem. Encourage them to do normal activities. The more they do, the more the brain learns that that engine hasn't been firing right, and it will adapt and compensate a lot quicker. I'll get onto what a VOR exercise is, and just warn them. If you've had a balance problem, when you're stressed, tired, worn down, ill, your balance might go a little bit again, just for a brief period, and then rectify itself. I like this picture. Don't operate machinery. I mean, this guy's going for the Darwin Award, if you've ever heard of it. The Darwin Award is anybody doing something pretty stupid to remove their gene pool, their genes from the gene pool. Kicking a log with jeans and shoes on into a log grinder. I'm not so sure that's very bright, but the message there is they shouldn't, when they've had balance problems, operate machinery, including cars, heavy machinery, or anything that could potentially injure them. VOR exercise, vestibular ocular reflex exercise. Really simple, it's portable, goes everywhere with the patient. Okay, what you want to do is teach the brain that there's a misfire or there's a problem with one of the balance organs. Put your thumb out at arm's length in front of your eye level, you look at the fingernail and you literally oscillate your head like that. That's all. It's not that, because you can't see your fingernail, it's just a simple quick oscillation. 60 hertz per minute. So it's literally a full movement in 1 second. Dead simple. Easy for the patient to do, and anybody with an acute balance problem, they do it seated. As things get better, you can do it standing with a chair to grab hold of if they're not feeling too great, and they can even do it on a folded towel or blanket to give that sort of wobbly, unsteady floor. But for anybody in the beginning, that is a simple little exercise they can do. If they want to challenge themselves, and get a post-it note and stick it on a vertical piece of wrapping paper or wallpaper, because you've got the visual input going on there and visual distortion going on. Really, really simple. Labyrinthitis is a sort of bad cousin, and you've just got to be careful of this guy. And the only thing I'm going to say, that's complete engine failure. And why I say complete engine failure, labyrinthitis is you've lost function in the cochlea and in the vestibule. The problem with that for you guys is that equals stroke. I would speak to medics before you spoke to an ENT. If somebody's lost hearing and there's no evidence of middle ear disease or outer ear disease, and they're spinning, they go off to the medics for a CT or MRI scan to exclude a stroke. But once the medics deal with it, and they're happy it's nothing serious going on inside the head, we'll take over their care. Okay? And it's the posterior circulation strokes you'll be very, very careful of. And the way I say is, if you can't assess cranial nerves because they're vomiting, you can't see the eyes because of nystagmus, get them to stand up. Somebody with a posterior infarct will tilt over, they'll lean into you, they'll fall over. Somebody with labyrinthitis will stand up and wait there. Because a posterior infarct will fall over. There is a mnemonic called HINTS. I wouldn't expect you guys to remember it, and I did allude to it last year in my talk, where it's head thrust, where you thrust the head in one direction to the bad side, and the eyes should go the opposite way. Which they should do even if you've had a posterior stroke, which is the head impulse is HIN, is nystagmus. Now if it's the ear, Alexander's law, it's in one direction. If it's a stroke, it could be upbeat, downbeat, and bidirectional nystagmus. Test of skew. If they will open their eyes, if you just cover one eye, cover another eye and get them to focus at a point, their eyes start acting like chameleons. They've decoupled themselves from in the midbrain. So they almost start moving up and down in the head. It shouldn't happen. That's worrying. And if they've got hearing loss with that, which is the plus, it goes to the medics. But again, the treatment of, if it's just pure labyrinthitis, is exactly the same as vestibular neuronitis, except we'll have to deal with the hearing at some stage. And it's again supportive. If they're dehydrated, it's fluids under the ENT. You can, if it's only mild, you can give them the vestibular sedative, cinnarizine, cyclizine, Stemetil. I always again watch driving, watch alcohol, give them that simple little exercise to do, and just warn them that they might feel when they're moving their head or they're in challenging situations for some time afterwards, they may be slightly off balance. Meniere's disease. I'm sure, how long have we got, guys? Let's make sure I'm not running over. Right, we've still got plenty of time. We're nearly there. Basically, it was grossly overdiagnosed 10 years ago. It's very uncommon. Very uncommon. Okay? It's difficult in a primary care to diagnose it because you need audiometric evidence that there's fluctuating hearing. You do, well, I don't know if any of you have audiometrists, but I'd imagine not. So it is incredibly difficult. If you're not sure, get it through to us on a routine appointment and we'll do the rest. But essentially, it's a little bit more prone in females. There is a familial history, so there's a genetic predisposition. And it's a disease of the 30s, 40s, and 50s. Often what you see is 1 year is normal and you lose the low frequency hearing in the affected ear. And eventually, as the disease progresses, you'll drag the mid and high frequencies down. And eventually the whole thing just burns itself out. It's usually a cluster of symptoms and there's a definite classification, and these are the patients that will have vertigo or spinning for between 20 minutes up to 12 hours but no further. They'll often have preceding oral fullness or pressure, roaring tinnitus, and they'll say, yep, my hearing went. And I had one this morning, which I'm treating. Okay. They generally don't have auras, or the only thing's pressure. They won't have visual problems, and they won't have the headache or the pounding problem. They won't get the brain fog afterwards, because once the ear resets, it all goes back to normal. They occasionally get the odd ones that make life difficult, that will have vestibular migraines and BPPV. Just get them through to the ENT department or a balance centre like Sheffield, and we'll deal with that. And basically, what can you do in the primary care setting? Well, again, support it. Just don't use these drugs for too long. You can start beta-histine in this condition if you think it's Meniere's disease. For the other conditions, vestibular migraine, vestibulopathies, labyrinthitis, it doesn't work. It really doesn't work. And I give them 8 to 16 milligrams 3 times a day. You can consider benzoylflumethiazide as the next rung, and then it comes to us. We'll put Gromycin, Meniere's device, intratympanic steroids, gentamicin, because it's selective to the vestibule as opposed to the cochlea. And then you start drilling out labyrinths and endolymphatic sacs and doing all sorts of weird things. But the mainstay of treatment now really is intratympanic steroids for these patients, and they do very well. I'm not going to go through this lot. I'm just going to say, watch these drugs. Watch these drugs in your elderly patient, because there is some little caveats. Particularly closed angle glaucoma, be careful. Pheochromocytomas of prochlorperazine, not that they're common, but be careful. Liver and renal dysfunction, just be careful. Parkinson's with it, hypothyroidism, heart failure. You see this all the time. Just be careful of these drugs then. There's no contraindication. Cardiac arrhythmias. And did you know, which I didn't know, that in elderly it can cause hypothermia and hyperthermia? It's like, oh, I didn't know that. These are all on your CKS NICE guidelines. Okay, again, cyclizine, there's a few things you just got to be aware of. And cinnarizine. Promethazine, I never really see it anymore. I'll touch very quickly on this guy. Superior canal dehiscence. It's one of my favourite. These are the eyeball squeakers. Often very strange. You've got Tullio's and Hennebert's sign. So when they have a loud noise, so that, you drop a pen, you drop a book, they go, oh, the world just went bang, up and down. They'll often say, well, I went out running, I stopped, and I could hear this pulsing in the air, and the world's just going up and down. You know, they go they pick something heavy up and they go, oof, I had to drop it because the world starts spinning, because there's a third window into the inner ear. There's no bone over there. So all the pressures in the head get transmitted onto the receptor in the superior canal. Likewise, noise coming through the tympanic membrane, go through the round and over window, but escape through that. So trigger the sensor. And because they can pick up sounds so well, they hear all their internal sounds. So that's why they hear the eyeballs rubbing against the eyelids, the food digesting, the joints clunking, the jaws clunking. They're an interesting bunch. And some of them get this, there's a spider running up and down my throat. I'm not sure what that is, but all the ones that I've had asked, do you feel something running up and down your neck? Oh yes. And I had one that was convinced it was CSF. So convinced he bought me pots of mucus as a present that I had to then send off to convince him that it wasn't CSF. He's still convinced though. And these are challenging, these patients. Okay, what do we do with them? I try not to do anything. It's nothing serious. Yes, it's a bit of a life, it can be inconvenient. Well, if they really are begging for surgery, you have to open the mastoid up and plug off the superior canal. You can open the head up, but then that comes with its own set of problems, and put a new surface over that. So what we tend to do now is just plug that off. Therein lies the problem. Well, that's working. Now you've stopped it working. So you swap one balance problem for another one. So when they move the head in a vertical plane, the world's unstable. If you put enough debris in there, you're going to get BPPV. All right, we can deal with that. If you open that up, it could switch off completely, complete engine failure. Yeah. So you've got to be careful, and they've got to understand that, yes, we can sort it, but you could be robbing Peter to pay Paul. So I tend to keep the surgery away for as long as possible. And if you look at the CT scan, it's quite nice. I get the radiology department to reformat the superior canal, and you can quite clearly see there's bone, 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 boom, no bone. So it's an interesting condition. Often it's also associated with spontaneous meningioencephaloceles. So your brain falls through the thin lining as well and bump into the middle ear. If you go and put a grommet in that middle ear effusion, yeah, you get a little surprise because it just leaks and leaks and leaks because it's CSF pouring out. And it has happened and it catches us out. Let me do that one. I'll just touch on imbalance because it's very, very common. All these, as I said, it's an aeroplane at the end of the day, your balance system. And I often say to patients, it's not just one component. They've all got to work together in harmony to move in a steady fashion. So often I will ask about ear problems, but you've also got to ask, particularly in the elderly, have they got visual problems, cataracts, eye surgery? Varifocals and bifocals really mess up balance patients. I don't know if anybody wears them, but you have to look down to read, you have to look over the top to see distance. And if you're looking halfway in between, you can get conflicting information into your brain, and it really makes them wobbly. So one of the things I say, just get reading glasses and distance glasses. Split them. Just watch your faulty wings, underfed pilot, polypharmacies in your elderly. If you can eliminate medication safely, do so. They come with a host of other problems, so cardiac issues, pulmonary issues, diabetes, neuropathies, etc. So of course they're going to be slightly off balance. And just remember, in diabetics, you can get numb feet. If somebody's over the age of 75, I tend to make sure they haven't got an ear problem. But if they're at risk of falls, I sort of say, please get them to see a geriatrician first if you're not happy, to assess them. Because often they need support, physio, OT, and adaptations of their homes to stop them falling before they come and see me. So if you've got an elderly patient who's wobbly and at risk of falling, rather get them down the geriatric route first, and we will happily take them off and exclude any peripheral problems from them. Rather than getting them to us first, they're still at risk of falls, and then going off to see a geriatrician 3-4 months later. Just watch the orthostatic hypertension. Usually these are fit well patients, but the ones that jump up and go, "Way!" For a few seconds ago, it's not spinning, but it feels like the curtains are closing around my eyes. I almost pass out. I have to hold on to something, and hey, I'm fine again. Often these are patients that are on a lot of medications that can control blood pressure. They're sometimes diabetic because they've got autonomic neuropathies. So sometimes just tweaking medication will help that. Sometimes it won't, and you have to be on medication to stop yourself going into serious medical problems. But I say then, look, you've got limitations, don't jump up. Get up slowly. If it's hot, make sure you stay well hydrated. If you're in a hot bath, don't jump out of it. Get out slowly. Otherwise you are going to go faint and you are going to fall over. You know, I always check in my clinic if you get symptoms of lightheadedness on standing. We always do lying and standing blood pressure, and you look for those significant diastolic and systolic drops. It takes 2 seconds to feel a patient's pulse and just check that they've not got an underlying arrhythmia. Sometimes I will then, if the primary care has not been able to deal with them, I will check it's not their ears, but they will go and see a cardiologist if I have to, for tilt testing. Just watch fad diets. There's a lot of these very odd diets out there at the moment, so people just eat proteins or just eat fat or just eat vegan diets, and often that leads to malnutrition or imbalance in micronutrients, which can also cause like anemia, thyroid problems, etc. So just watch that. Love that. Somebody said that's the famous scream, but if you look at it, it looks like a spaniel. Loppy ears. Generalized anxiety and stress, I often find it really hard work because anybody with a peripheral vestibular problem, if they're of that disposition, they're an anxious, type A, driven, like to be in control, and suddenly that's out of control for whatever reason, often they won't engage in a lot of the processes we're trying to. They don't turn up for the scans, they don't go to the vestibular function tests, we put them into visual vertigo retraining, they don't engage, we put them into physio, they don't engage. And often what I have to say is, look, we're trying to help you, but I can't, because your anxiety is stopping it. You need to get that under control, and it's usually then the appeal will come from myself to the GPs in the Sheffield area. Please can you address the anxiety, use the IAP service, I give the patient leaflets, and occasionally, and we used to have the service but it's on hold, we use our in-house psychologists to help them first come to terms with the balance problem and then engage them back in rehabilitation. I'm just going to touch on this. A lot of balance patients, despite anxiety, depression, etc., will develop persistent postural perceptual dizziness. What they've done is they've leaned too heavy on their vision when things are wrong with their ears. It's a bit like spraining your ankle. You lean on the good side. Once the ankle gets better on the other side, you'd hope you'd straighten up. Some patients don't. They're so visually dependent. These patients would love this carpet. They'd come in and go, "Ooh, no, that's awful." You either go into Tesco's, Asda's, Sainsbury's, and they go, "No, I don't like them. There's too many vertical, horizontal lines, vertical lines. There's too many patterns on the floor." You say, "Well, can you go to Meadow Hall?" "Oh, God, no. There's too many people walking across my visual field." You go, "Well, you know, can you use the escalators, particularly those nasty ones with the little stripes on them?" "I don't like those." And you go, "Can you watch a TV program with sporting event with fast moving things on screens or fast action scenes on a movie?" "Oh, no. Stop doing that." And basically what they've done, and we've got a situational score, so irrespective of what the balance problem was, they've now become too visually dependent. So often, and amongst all this conundrum of anxiety, stress, peripheral pathology, you've got a maladaptive visual vertigo going on as well, or persistent postural perceptual dizziness. And it's mostly, if you ask them, when they're upright and in motion. When they're seated and lying down, it doesn't happen as much. But put them up and in motion, they fall to bits. So often we have to go through desensitization over and above CBT, over and above the rehabilitation to get patients right. So you can see how complex it gets. Central, as I say, I'm not a neurologist, but basically, if it doesn't obey Alexander's law, be careful. If it comes with dizziness and hearing loss, be careful. If they can't stand and there's any other cranial nerve signs or extrapyramidal signs, be careful, get a medical opinion. Often patients with central problems, be it stroke, bleeds, tumours, vertebral artery dissection, Arnold-Chiari malformation, maldubartment, often they go, "Yeah, the room's spinning violently around me, but hey, life's good." They don't care. They're not as bothered by the spin. Your ear patient hates the spin. Suddenly, the world's violent and they get this intense autonomic response, whereas the centrals don't do that, generally. They often have headaches, and there's a little list of some of the conditions which you probably get access to. These are some of the signs. So nausea with centrals, very mild, if any at all. Whereas in the peripheral, it's severe. Movement again, they'll have a degree of spin, but it won't be as violent as a peripheral problem. Head movement, they'll be quite happy moving their head around. There won't be these, I don't want to move my head because I hate it sort of patients. Imbalance, it's severe. That's what I said, they will fall over. They will not take the weight, whereas your peripheral will take weight. They won't like it, but they'll take the weight. Oscillopsia, strange old word. It's severe and central. The world's bouncing around. Your eyes have uncoupled themselves. Unless you've got bilateral vestibular failure, which is incredibly rare, you will not get oscillopsia. Oscillopsia is whenever you're driving in your car, your world isn't bouncing around. But oscillopsia is when if both vestibules fail, if you have a central, when you're driving any motion, the world's just bouncing up and down. It's horrible. Caloric test, I wouldn't worry. We don't really do that very much now. And central take months. Peripheral, depending if there's coexisting anxiety and maladaptive behavior, usually takes days to readapt.
Sorry, it was just that you said quite a few times, obviously, if there's hearing loss associated, then really think central. And on there it says hearing loss is rare in central but common in peripheral. So I was just wondering if there was anything.
Yeah, look, vestibular neuritis, you're not going to lose your hearing. Meniere's disease, you might. Migraines, they think they have. They haven't.
So actually, if it is a central cause, it's not very likely to lose your hearing.
If it's a central, look, if you've got somebody who's spinning, keep it simple. With any hearing loss, when you're sitting in your GP surgery, treat it as a central problem. Because the problem you have is you don't have an audiogram, whereas we have it, so we can check that. You can try a tuning fork test, but again, tuning fork tests are only accurate in 50% of patients that lose more than 20 decibels of hearing. So it's grossly inaccurate. Just ignore. I would say, as an ENT surgeon dealing with this, if central, it may or may not happen, but if you've got somebody spinning with hearing loss, it is most likely their ear, but it could be a posterior stroke. They're rare. But what we don't want in ENT is somebody sitting with some bleed going on in the medulla oblongata and the cerebellum, swelling and edematous and coning themselves. Because they're sitting in a little side room because we're packed out with tonsillitis, nosebleeds and head and neck cancer, and they go missing. So there's a rule to anybody, if it spins with hearing loss and will not weight bear, and nystagmus is up, down, bidirectional, get it to the medics. Okay, simple rule, it'll keep you out of trouble. If that answers it. Or am I becoming sort of political and skirting around?
No, it's fine. You've got a very different job to us, so it's absolutely fine.
I fully appreciate that I've got all the bells and whistles. We've got CTs, MRIs, vestibular functions, audiograms, which you guys don't. So I'm trying to keep it, if it's not following the simple rules, just get it to the medics rather. Medics first, then us. What not to do is don't panic, okay? Just avoid labeling. One of the hardest things I've got is if somebody's given somebody the diagnosis of labyrinthitis, Meniere's disease, and I turn around and say, no, you don't have it. Because what inevitably has happened in this day and age, they've been on the internet, they've read all around it, and they've convinced themselves they've got that problem. And I've got to try and unpick it. So it becomes incredibly challenging. I just say you've got a balance disorder or a vestibular upset. It keeps it rather vague. Just watch long-term Stemetil. It's a problem. It really is. So yeah, short-term, wonderful drug. I've got nothing against it. Long-term, just be careful. Speak to the ENT. Speak to medics. If you're not sure, speak to us. Okay? And if you're not having any joy with the juniors, find a consultant. We're usually okay. If it's a head and neck consultant, they'll probably pass you on to the neurotologists or the ear surgeons because their balance knowledge is, anyway. Manage stress and anxiety if you can. Triggers. If there is a migraine, get them to see about, do they know their triggers? Talk about, I call it the deadly C's. Red wine, claret, caffeine, chocolate, cheese, MSG, which, they put a lot in Chinese food. VR exercises, simple. Look at your thumb, shake your head. Change spectacles, particularly in elderly patients. Varifocals and bifocals cause problems because of the visual conflict. Flat shoes, if you've got heels or wedges, your gravity's in front of you, you're chasing it. It's a simple thing like that. A walking stick for dark, unfamiliar, uneven environments. Really useful. Modifying hazards, nobody can do that, but maybe get the geriatricians to assess them. Falls risk, please get the geriatricians to see them as well. And look at the medications. Often patients are on a host of medications that they don't necessarily need to be on. So do be vigilant. DVLA, really simple. If the attacks are unprovoked and spontaneous, so you've got no warning, just comes on. You don't want to be doing 120 kilometers. You don't want to be doing 70 miles per hour down the motorway and boom, you're across all the lanes. That's dangerous. Likewise, that's class 1. Class 2, if you're in a bus or a truck, can you imagine? So the onus is on the patient to contact a DVLA. And they have to inform it, and they will ask for a specialist opinion regarding ongoing treatment and diagnosis. The quandary comes if you've told your patient they should inform the DVLA and you see them driving. You're well within your legal rights to inform the DVLA that you have told this patient that they shouldn't be driving, but you also have to inform the patient. I've seen you in the car, we've informed the DVLA that you shouldn't be driving. It does get sticky and it can open up a whole can of worms. There is a whole link to the DVLA. Fortunately, most of the conditions we get, patients know it's coming and they can stop or they can get to a place of safety. Penrose Stairs. I do laugh because that's just the world going round and round forever. I sometimes think that's me sitting waiting for them to come and see me and you're going, what to do with it? Okay, it's a very big and complex area and I hope I've tried to simplify it as much as possible. More than welcome to come to a balance clinic if you wish. And if you have any balance patients, Barnsley does have an ENT service, but if they really are struggling, I think through Choose and Boot you can refer to Sheffield as well. And we do balance clinics every day. Okay. Any questions? Or have I made you completely bamboozled and spinning? To me, this is a simple world, but to everybody else, is like, good luck. I will just refer them through to you for a specialist opinion. There's just one last thing, guys. I just want to make you aware, and I'm not trying to plug this, no conflict of interest. There's one other condition very close to my heart, and there's a big collaborative meeting tomorrow. Be very careful of this condition. It's on the rise, it's lurking out there, and it's dangerous. It's a diabetic ear. Okay, I call it diabetic ear because it's very common amongst elderly diabetics who have picked, prodded and poked at their ears. Anything that damages the skin of the ear canal, and that includes syringing, can cause otitis externa. But in diabetics, frail, immunosuppressed patients, the infection dives through the bone between the cartilage and ends up in all the soft tissue around the jaw joint. And it's called necrotizing otitis externa. I've had 8 under my care in 6 weeks. They require 12 weeks of IV antibiotics and it's costing a huge amount to all the NHS trusts, and we're having a big consensus meeting tomorrow about management on it. It's on the rise, so if you get an elderly patient or any patient immunosuppressed with otitis externa that does not settle within a week, get an ENT opinion, honestly. And if the ear looks anything like that, with granulation, inflammation and edema, do not sit on it. It's a very nasty condition. Try and avoid using ciprofloxacin as well. It's a last chance saloon after IV antibiotics to use Cipro drops and antibiotics orally. But just be careful. If you get a patient with severe, severe pain keeping them awake at night, discharging ear and jaw stiffness, those are really worrying signs. And if the facial nerve goes, then it's really worrying. Okay. I just had to put that in because it is concerning now and we're working hard to get information out to people. Okay.